Welcome back to the Intent Medical Group podcast, where we explore the science, stories, and innovations shaping the way we live and care for our health. I'm your host, Dr. Sammy Clilly. I have the pleasure of welcoming Dr. Christopher Todd Anderson, Director of Epilepsy Monitoring at Intent Medical Group. Dr. Anderson is a nationally recognized neurologist specializing in seizures and epilepsy and related neurological conditions. Originally from New York City, he trained at Columbia University, completed his fellowship at Stanford, and went on to serve on faculty at both the University of Pennsylvania, hey Philly, and the Medical College of Wisconsin. Now leading our epilepsy and seizure division, Dr. Anderson provides comprehensive care using a truly multimodality approach, from medications and lifestyle changes to advanced devices and surgical options when appropriate. So let's get into it. Dr. Anderson, Christopher.
Thank you. It's great to be here.
Yeah, it's our absolute pleasure to have you here. This has been a long time coming, and we're super excited to talk to you about all the things that you have a tremendous wealth of knowledge about. But before we get into all that, I want to learn what led you into this path. A person like yourself, as I've come to know, could have done so many different things. I
was originally planning to be a musician, but I wore out my arm.
Okay.
And I had to pick something else.
What was your instrument?
I was a jazz drummer.
No way.
But I also play piano. And I really had to sit down and pick another career because I knew it was coming to an end.
Mm-hmm.
And after just a lot of reflection and investigation, what I could do, I was like, this is fascinating. I want to take care of people. A lot of advantages to it. It's hard. I love that. And I knew I wanted to do brain science.
Okay.
From before I went to medical school.
Okay.
So even as a pre-medical student, I was a research assistant in neurosciences, psychiatry, and neurology. And I always, from that point on, age 20, I knew I had to do something like psychiatry or neurology or neurosurgery or neuroradiology. The brain was definitely my organ. And that's true to this day.
That's very evident. But when did that happen? Because music is a very different field, but I can see some similarities. But what was the trigger that said, nope, obviously your arm wasn't working, but in terms of deciding, okay, the brains was where it was at. Was that an earlier on stage? Were you always intrigued by the brain and spinal code when you were younger?
Kind of simultaneously.
Okay.
I said I'm going to go into medicine because I want to be a brain doctor.
Was there an aha moment, something you saw or something you seen or a person you encountered?
No, there's no kind of storybook. Oh, grandma suffered from this. I now this is my calling. No, it's just all the different facets of brain science and breakthroughs that were being made, technology, imaging, relating to people, the relationships between lifestyle, emotion, and wellness and disease. And it was just such an explosive time. It still continues to be, finding new treatments for difficult diseases like epilepsy, which have been around for thousands of years.
There's so many things and parts in medicine that you could decide. Like you said, brain science includes a huge umbrella of stuff, including stroke, neurology, or neurosurgery, or...
A doctor can't know the whole body at this point.
Right.
Know all the treatments. And it's gotten so subspecialized that no general neurologist could know about all the movement disorders, dementias, epilepsy, headache management, back pain, that there are specialties and there are even subspecialties. So within the field of epilepsy and seizures, my specialization is in inpatient monitoring of patients with seizures, working them up, seeing them in clinic, and being what's called a surgical epileptologist. So I have to kind of crack the code about where the seizures come from and work with the surgeons to figure out what are the optimal treatments. And now that we have 5 to 10 different modalities of brain surgery is vastly safer now than 50 years ago. And you can take a person with a disabling disease like epilepsy, which just means recurrent seizure. That can be a minor hindrance to certain activities, but for some people, it's devastating in terms of derailing their life goals. Epilepsy care has gotten to the point where we can get people's lifestyle back to normal, back behind the wheel of a car. They can go to graduate school. They can be a professional musician. They can be a professional athlete. And it's just so satisfying. I'd say the most disappointing thing about my job is that I don't get to do it forever. So I'm getting older. Someday this is going to end. And my younger friends are now making all these fascinating devices that go in your head. The surgeons are making wonderful strides with things they do in the operating room. And I'll move along, and I'm going to miss all this future stuff.
But that's a sign that you found your calling. That this is definitely where you should be.
Absolutely.
Yeah.
And I really, picking this field, I'm going to contradict myself. It took a lot of self-reflection. What am I good at and what do I want to do? And then on the other hand, it was kind of like, this is just so natural. I kind of knew it. There was nothing about it that made me think I won't like this. This is going to be too much. Mm-hmm. The harder it gets, the more I want to do it.
That's a great attitude to have in general, in terms of for young people to know, deciding what you're trying to decide for a career in the long term. One of the things I know for myself that is, just figure out what you are actually good at, and then use that as a platform to figure out where your interests may lie for what you might want to do long term. And it sounds like that's kind of what you did, right?
Well, you're more comfortable.
Yeah.
If you pick something you're going to be good at, you're more comfortable. It's a pleasure. The more you do, the more you like it.
Yeah.
Whereas if you're bad at something, you might conquer your personal mountain, but the satisfaction is going to be totally different.
That's right.
So for me, it makes life easier spending a ton of hours and challenging myself intellectually and working in a very diverse field.
That's great.
You got to be reasonable. What can you do? What are you good at? What's going to be fulfilling? What are you going to accomplish? Mm-hmm. And just because it's hard, that's probably a good thing.
Right.
If it's hard. If it looks too easy and you're just going to get rich, then, you're going to sit around. You're not going to accomplish anything. Your sense of calling won't be there.
Your sense of fulfillment will be down. Yeah.
Right. So every day I wake up, I'm like, I'm tired, but I can't complain. I get to do fun stuff. I work with great colleagues, and most of all, I work with great patients.
That's excellent. And I'm sure I can tell very much, and I know personally that they all love you tremendously. So that's a very positive thing.
That's great to hear.
I want to kind of help the audience to know how they would encounter you at the first go. So given the fact that you deal with people who have more chronic seizures, do you see someone at the first level, the first seizure presentation, or is there more workup done before they get to you?
So the patient has their first seizure. They come to the emergency room. They get a standard workup, which is usually a CAT scan or an MRI, and an EEG, which is recording electrical activity of the brain from the surface of the scalp. Mm-hmm. And we get pretty good information, what was the cause of the seizure. The fascinating thing about taking care of epilepsy patients is there's a lot of detective work to be done. So if we do the scan and we find something serious, like a malignant brain tumor or cancer that's spread to the brain or a abnormal cluster of blood vessels, then that's kind of the clue. This is the area where you have to focus your attention. Whereas most patients with epilepsy, they have normal looking brains on a scan, and they have normal brain waves in between the seizures. And I have to do a lot of detective work in the clinic to figure out what actually happened. So whereas an ER doc will see very complicated things, but they'll also see things that they can manage really quickly. Mm-hmm. My first patient visit is pretty much always an hour. It takes that much time to piece together all the stuff that's happened in the person's life and their unique sort of equation about how the seizure started, what the seizures look like. Most of the time, I don't get to see it. It just happened. I have to get witness reports. Then I have to piece together, where the seizure came from, what is the cause, which we call etiology in our field.
That's right.
And then what to do about it. Mm-hmm. And for me, that's fascinating detective work. And people who work in the branches of medicine who can, see a broken leg, in 1 minute and say, you need a cast or you need to go to the operating room. For me, the patient's totally normal. The event happened 2 months ago. I have to do a lot of detective work. Now, the problem is somebody like me who does this all the time, day and night, gets good at eliciting the information and to put the puzzle together and make an appropriate individualized treatment plan. Now, the patient who comes to the ER with the first seizure, who gets CAT scan, maybe gets an EEG, and continues to have seizures, the delay in them getting to an epilepsy specialist and even getting to the operating room is on the order of decades.
Is that a function of not too many epilepsy surgeons existing, or is it?
They just don't know. The information's not there. And I inherit patients because, their general neurologist retired or, moved on in their stage of life. And I like, oh my God, all these opportunities have been missed. And the patient's like, why didn't anyone tell me this? And it's because the doctor didn't know. It's easy to get, it's hard to stay current. And like I said, with ultra specialization, knowing everything in a big branch of medicine is almost impossible.
Yep.
So the biggest hurdle right now in epilepsy care is getting the patients hooked up with the right doctor without a substantial delay, because that is the impediment. And there also aren't enough epileptologists. There aren't enough epilepsy surgeons, and people just don't know what's out there. But I'm one of those guys on a crusade who's really trying to spread the word. We have all kinds of treatments, very creative. Patient gets to decide what they want. They actually work with new technology. Computers do a great job of analyzing brain activity, but also we have implanted devices that go into the brain, and it's a brain-computer interface. So it's like having a prosthetic brain that can interact with the seizure focus and try to get rid of the seizures. And since even a lot of neurologists don't know this, and people in general medicine, they don't even know an epileptologist exists. But my job is to work them up, make a diagnosis, make a theory about where the pathway is, what the cause is, and work with the surgeons and other members of the team to make a plan tailored to that. And you have to do this day or night. And anyone who puts the effort in, like me, it takes decades to know everything that's available. But that's why I'm here. And I had a unique opportunity when we started our medical group. I wasn't there at the start, but to join a practice that was really committed to treating a bunch of branches of epilepsy and, branches of neurology and neurosurgery. And epilepsy was one of the first 5 or 10 that they picked. So I got to come down here, set it up, from scratch. This is the way I would do things. My whole life, I had a gripe about this, that, why did they do it this way? Who set this up? Well, he's been gone for 20 years. So now if I don't like something in our epilepsy program, it's my fault. It's probably my decision, but it's really nice. And I have a very supportive team.
And I'm sure that you probably feel now that because you have more control yourself for this, it's probably going more often better than you had done previously.
Well, I'm used to working in big academic medical centers. So the team was always big. We had 3 or 4 or 5 epileptologists, 1 or 2 surgeons. Now it's just me and my partner, Asawaf. So it's kind of weird. Everyone in the room's like, what do we do? And all of a sudden, I'm the guy who makes the plan.
Yeah.
So it was kind of like a big turning point in my life. From being a junior guy to a member of the team to a person who has a lot of experience, and now I'm ready to go out on my own and set it up the way I think
I hate to use the word, but you are now the senior guy.
The sad truth is we all grow old, but let's make the best of it. There are advantages to having done something, done it well, and it's been fulfilling, and hopefully I have another few decades in me. But
I'm sure you do.
It's a little disconcerting being the guy who makes some big decisions now.
In an effort now with this space existing and other vehicles to kind of get information out there to patients, if you were to tell the public right now 2 or 3 simple things to do or to help begin the process to get access to someone like yourself, what would you tell them?
It's actually pretty straightforward. So the big medical societies have made guidelines, and if a person has a seizure, they need to see a neurologist. If they try a medication and it doesn't work, and they try a second medication, it's called refractory epilepsy, and they have to go to the highest level epilepsy center who can step in.
That's it.
That's it. The patient has to be referred. Those are the rules. There's no recourse if it doesn't happen, and it doesn't happen 95% of the time. But if you try two meds, you still seize, you got to go to an epilepsy specialist.
I want to sit on that for a second. So very straightforward. If let's say you have a seizure, and even if it's just one, and then they put you on medication.
Yep.
And it didn't work, you try a second medication. It doesn't work. And when we say we're talking about the neurologist.
Go up the ladder.
You're supposed to be going to an epilepsy center of some type.
That's it.
But if 95% are still not getting there,
they sit around for years having seizures.
Is that a result of systems not knowing that that's the pathway they should take, or is it patient driven?
It's not the fault of the patients ever.
Okay.
When I tell the patients about the new treatments or the problems with the old treatments and why we need to change things, they're always surprised, and most of the time they're really enthusiastic that there are opportunities.
Wow.
They didn't drop the ball. The medical system did, because people weren't disseminating the information well enough.
Gotcha.
So that's one of the things I do as part of my job, is get the word out there. Don't let them seize. Every time a patient has a seizure, within reason, I want them to call my office, because I got to change something.
Yeah.
One seizure a year is too many. So the goal of epilepsy care is no seizures, no side effects. And if you haven't achieved that, you need an explanation why, that you understand as a patient.
Yeah.
And or you need a referral to somebody who could take another crack at it and make you seizure free. No seizures, no side effects. If you haven't made it, pound away. The system has to take care of you, has to intervene.
That makes sense.
It's not the patient's fault.
No.
And the resources are out there. For some patients geographically, it's hard to get into an epilepsy center, but most major cities, every state has an epilepsy center. It's pretty much available. It might be a hassle for some people, but if you live like on the East Coast, West Coast, Midwest, there's no excuse.
Right.
We're sitting here
with a lot of people, like a lot of choices and a lot of options for people to go see. Yeah.
Absolutely.
Yeah. No,
so
I agree.
The next region we're trying to conquer is the Chicagoland area.
Okay.
So Chicago's pretty well covered, but out here, like Arlington Heights, Palatine, all the little
Hinsdale, Elgin, all those things here.
Towns,
Yeah.
they're not getting state-of-the-art care. And that's a shame.
Because, truly is, yeah.
Because we have the talent. We have people who want to help, but they're just not getting sent in enough. So that's why I'm out there pounding the pavement saying this is the disease. The goal is seizure freedom. If you don't get there, look around. And, with the internet, patients will come to see me and they'll be like, I saw you on the internet and I heard about this device you're using. I got to go see this guy.
Yeah.
And I'm like, that's fascinating. 50 years ago, they would never know.
That's
it
right.
would be like totally siloed, done in one hospital. Now, patients are the ones who are doing a better job of seeking the appropriate care than doctors are doing, referring the appropriate patients to me so I can check off all the boxes. Now, I practice what I call multimodality care.
Yep.
Person comes with seizures. One, you got to make sure it's not something progressive or dangerous in their head. That's an emergency. And you start with medications. And there are about 20 medications available, and you can pick good ones and bad ones based on like lifestyle issues or whether they're going to have a baby. And then if they try medicines and they don't work, we move on to lifestyle changes, or we do that concomitantly with the first step. That means avoiding their triggers. So for a lot of patients, it's sleep deprivation, flashing lights. Some people have reflex epilepsies. They will seize in response to a certain sound or a certain place or even a certain taste in their mouth. It's fascinating. And we use hormonal therapies. A lot of people have seizures in a cycle, which is related to their hormonal cycle, which can be regulated very easily with medications and lengthened, and then the seizures are more predictable. We have special diets like the ketogenic diet, which 20 years ago was considered a sort of laborious, fancy medical intervention. Now, you go to your local drugstore and they have magazines like keto recipes. Patients could do it on their own. Give it a shot. It's harmless. To permanently fix a cause of epilepsy, if possible, brain surgery is the best. But figuring out where the problem is and what to do about it and is it safe is a lot of work. It takes a lot of effort on the part of the patient, and the doctors have to be really smart and really cautious. And not to exclude the things I've mentioned, there are now devices to treat epilepsy. There's one that goes in the chest, which is called a vagal nerve stimulator. Usually involves a 1-day hospital stay, at most 2 days. Sometimes patients can go home the same day. We also have an electrical stimulator that goes into the center of your brain called the deep brain stimulator, which the technology's been around in other areas of neurology for 30 years. But now we know how to treat epilepsy with it. And now we also have a device called the responsive neurostimulator. And if you integrate the responsive neurostimulator, the RNS, if you integrate the RNS into the seizure network, you can interact with the electrical activity and abort the seizure before it becomes clinically manifest. And that device is a favorite of mine. It saves all the data. The patient can upload their brainwave tracings non-invasively from their house. They can call me. I can look at it the next day, say, oh my God, they say they bit their cheek. They don't know what happened. It was the middle of the night. I can read the brainwaves after the fact and say, yeah, you had a seizure at 2:14 a.m. It lasted 45 seconds. It started on the left contact. The device was a little late. I need you to come in the office. I need to make an adjustment. So the technology, since computers are getting so much more powerful, storage is getting huge. And with artificial intelligence, the computer teaching itself where the seizure starts, how it propagates, what the electrical properties are, what kind of responsive stimulation the patient should get, where and for how long, and what type of electrical current. None of these devices essentially does the patient feel when they have a device, either one in their head or one in their chest. So it's only going to get better. And like I said before, the thing that disappoints me is I'm going to miss out on these things 50 years from now and 100 years from now.
But you're seeing them in their infancy right now in terms of
No,
how they're coming,
and
you've
I
seen them
get to be
beyond.
a part of the, it's a big group, but the group of people like designing applications and tuning it and figuring out what works and what doesn't. It's inspiring.
That's amazing. So when you're talking about multimodal treatments, are you saying that when a patient comes in with epilepsy or whatever version they may be having, that you will have to apply all of those multimodal treatments, or do you have a ladder approach in terms of how?
Yeah, there's
an
there's an algorithm.
Okay,
but it's different for every patient.
And what kind of factors determine the differences?
The seizure types determine which medications will work, which devices might work. Is brain surgery an option?
Okay.
Lifestyle triggers, that starts on day one. Like if you seize in response to a certain stimulus, you got to stay away from that from now on. It's different for each patient, but no, I typically go in a stepwise fashion. Let's try one thing at a time. If it's a medication, if it's a device, medications, I'll give it a month or two. If it doesn't work, we're done.
Right.
We move on.
Right.
If it's a device, you got to give it like 3 to 6 months before giving up on it. If it's a diet, same thing, 3 to 6 months. Brain surgery, where you actually take out parts of the brain or disconnect them, there's a big workup that gets done on the outpatient basis, but there's also an inpatient workup that gets done in the epilepsy monitoring unit where we actually provoke seizures. So I can see what happens to the electrical activity during the seizure, and on video, what is the behavioral change. And that is another clue as to where the problem is and what the options are. And then there are other tests to see, like, how is the brain functioning, advanced imaging like MRI, functional MRI, PET scanning, magnetoencephalography. There are pencil and paper memory tests. And
so you have a whole battery of things.
A whole battery of things. But like where we take it really depends on what the goals of the patient are. So there's a spectrum for all kinds of behavior, but I'm just going to make one up right now. So there's the patient who has maybe advanced age, may have something like Alzheimer's disease. They don't drive a car. They live in a home where they're supervised. They have other medical illnesses. Like, is it really a priority that we take them to the operating room for a big fancy surgery to try to solve the problem in the most aggressive way? And then there's the other side of the spectrum where maybe the patient's like a 20-year-old woman. She wants to go to law school. She wants to drive a car. She wants to have kids. It's hard to have kids when you're on 3 or 4 anti-seizure medications. They want to be thinking clearly. They want to be awake. You know, imagine taking psychoactive medication for seizures and then try taking 5 of them at the same time. It's like living in a fog. You know, I have to say to that person, what are your goals? And if they say, I want to drive, I want to be a lawyer, I want to get married, I want to have kids, we're going all the way. And we got to check off every box. And I would say, theoretically, before we give up, but we never give up. And
well, I guess what you mean by give up is more give up on that specific treatment.
Well, we've run out of things to try. And I've only gotten there like once or twice.
Where you've literally gone through the whole gamut of everything.
I had a patient who I got very close with because I saw her a lot. She was very motivated. She had really severe epilepsy, still highly functional, but seizing at least once or twice a day. We got to the point where she was on 7 or 8 traditional anti-seizure medications. She was on a CBD product. We also have that. That's a box to check off. She had what's called catamenial epilepsy, so her hormonal changes would provoke seizures. We eventually sent her for a hysterectomy to manage that part of it. We treated the seizures.
To manage the hormonal portion that may be affecting her seizures.
We had to go all the way, take out the uterus, do a full salpingo-oophorectomy. She had a device in her chest, which is the VNS. She had a device on the cortex of her brain, which is called the RNS, responsive neurostimulator.
Both working at the same time.
Yep, and she had a third device, which is a deep brain stimulator. So I had 3 computers running, interacting with her brain. She was on the ketogenic diet. I can't remember. We've probably tried other things. And, you know, we improved the situation. We never made her seizure free. Luckily, she had a lot of doctors. But I could go to sleep at night knowing, like, did I try everything possible? Like, am I being creative? Like, should I send her to a colleague? And that was one of the few. I'm like, for the moment, we have done everything possible. And hopefully in 6 months, we'll have something else we can try. And now we're in that stage where there's a lot of flux, new things coming out, devices to monitor seizures, like seizure detectors. Some are abnormal movement detectors that are like a wristwatch. Some are applications on your phone. It's just expanding and expanding and expanding. And it's an effort for me every day to keep up with what's available and make sure, you know, if I get struck by lightning and the patient has to go to a new neurologist, I want that new neurologist to say, like, oh my God, Chris Anderson did everything humanly possible. I cannot think of anything else. Because if they go to somebody else and they're like, why didn't he try this? He missed an opportunity for you. I haven't done my job as well as I could. So that's, you know, my priorities in my day. You know, my family, my wife, taking care of myself, being a good doctor it's up there and equal to the most important stuff.
That's excellent.
And then there are, secondary things which contribute to me doing a good job, which is like pounding the pavement, doing podcasts, explaining how exciting
Trying to get the
this
message
is.
out there, yeah.
Get the message out there. Don't continue to have seizures. Sometimes we can actually fix it, or we can get rid of 90% of the seizures,
Well,
which for some people is huge.
Over your lifetime, you must have seen thousands of people at this stage.
Yes.
Yeah. And for you to say that no one can fix everybody, but
No, there are some patients where we try everything possible,
Right.
and they're still going to have seizures.
But I'm more trying to give you the positive feedback and compliment that, like, if you can only think of one or two out of the thousands that you've seen that you've hit the mat on, that you haven't felt like you've made the betterment that you could, that's still pretty good. Not perfect, but I mean, still pretty good.
But so there are a lot of patients who don't want everything.
Right.
So they're on
Right.
that side of the spectrum. Like, I've lived with this my whole life. I'm getting old. I have heart disease. I don't want to go into the operating room and get brain surgery. That's their choice.
Right.
But I have to educate them and know, like, we're ready
Right,
and willing
right.
if you become willing, if your life priorities change. And that is a substantial percentage of my patients. I'm guessing like 10 or 20% have just lived with it. This is the best they've ever been. Why mess with something? They're accustomed to it. They're 50. They're not going to make major strides.
Mm-hmm.
So I do have patients that continue to seize, but I have offered them other modalities that they haven't tried, but they're just not on board. And that's okay.
Mm-hmm.
It's a free country. I support them. They know what's best in their life. I don't.
Right.
But if they're saying, give me everything, I love it. The harder it gets, the more I want to go to work.
You like to rise to that challenge every single time.
Yeah.
That's awesome.
I'm so grateful that there's a lot of diversity in what I do.
Mm-hmm.
So I need to know a lot about chemistry, about how medications work, how they interact. I need to know about prenatal care. I need to know about elderly care, neurodegenerative diseases, brain tumors, strokes, traumatic brain injuries, things like illicit drugs, a relationship with alcohol and lifestyle, safety. And then I also have to read their brainwave studies, which are called EEGs, which is not direct patient care, but it's kind of like a technical thing. And then I have to work with all the other teams, like the cancer doctors, the brain surgeons, the radiologists, for making plans. I get to go to the operating room and kind of direct where I want things to go. Sometimes I don't need to go. It's very straightforward. Sometimes it's very complicated, and they want me there, like, stand behind me. I don't do any surgery, but I'm 6 inches away saying, that, no, you got to get that electrode a little bit deeper. And then, there's so many other components of my job. It's just so diverse that I never get bored.
That's awesome.
And my boss at IMG, who's Dr. Kassam, is a really creative doctor, and he wants people to have diverse talents within their own practice. So for me, that's a great opportunity. And I don't have to do the same thing all day long. That's my worst nightmare.
Well, it sounds like you're achieving all those goals for sure. I guess my only other question I would have to ask you, because you've done such a wonderful job of taking us through everything from the journey the patient has to the challenging patients you've had to the multiple different types of choices people have, what's multimodality therapy. I've learned a tremendous amount just listening from you in the last few moments. If you were to try and guide or encourage a young person who is maybe not sure that they want to go into a field like yours, or maybe think they like it or interested, what would you say to them?
I don't think the whole world needs to treat epilepsy. But I think I've been lucky in my life. I've seen a lot of things. I've met a bunch of wonderful people, patients mainly. Patient care is not stressful for me. Their stories and trying to help them is very fulfilling. And I don't mind spending the day, and that's my social life. And then I get to do electrical studies, so forth, get to do outpatients, inpatients, ICU care, operating room time, teaching. So whatever you like to do in life, whether it's like law or music, being an artist, being a politician, being a person who runs a home, I think diversity is good. I think having an open mind is good. I think using different techniques, keeping an open mind, don't be arrogant. Don't think you know everything. Everyone has stress in their life.
Absolutely.
But I get to do like 10 or 20 different things. I'm always learning something, and I'm always learning something for people. And if you have a seizure, I'm one of the people you should come see. And if I'm not, I can find the right person for you.
Well, can't thank you enough for coming here. I know that all of us at IMG are beyond grateful and happy to have you as part of the team. You've been an amazing, amazing addition.
You're way too nice. Way too nice.
Not at all. Not at all. It's genuine. We truly mean it. We especially love your hat when you come in every day, that you wear. And everyone thoroughly enjoys the stories you have. So.
On that note, it's been great.
Oh, it's been a pleasure.
Thanks so much, Dr.
Absolutely. Absolutely.
Oh, yeah.
Well, that wraps up today's episode of the Intent Medical Group podcast. Thank you for tuning in. If you enjoyed this episode, don't forget to subscribe, share it with a friend, and leave us a review. Until next time, we'll see you later.